Okay, so are you all ready for chapter 13? Let's start chapter 13. So chapter 13 talks about the peripheral nervous system. So when we say peripheral nervous system, we have already talked about the central nervous system. So when we talk about the central nervous system, we already know that central nervous system is actually made up of your what? Brain and the spinal cord. But what about the peripheral nervous system? What do we mean by that, first of all? When we say peripheral nervous system is basically the pathway to your central nervous system or from your central nervous system, right? What is the function of nervous system anyways? The function of the nervous system is to communicate with the environment and take action based on the information you have received, right? So for example, I am saying something and then some of you are nodding your head. So what does that mean? You are receiving the information, which is my voice, and then you are looking at me with the eye contact, you are nodding. That means that you are telling me that you have understood, right? So who is doing that? We know that your central nervous system is the what? Central nervous system is always the integration center, which is telling you to do something, right? We already know who takes the action. Who takes the action? Always your muscle takes the action, right? That muscles could be your skeletal muscle, that muscle could be your heart cardiac muscle, that muscle could be your smooth muscle, like your all the everything that you have inside your body, all the hollow organ like your stomach, all the glands, all those, right? So they are the one who is taking the action. So to tell them to take the action, you have to send the information to those muscles, right? How do you send the information to those muscles? By the peripheral nervous system. And who's bringing the information to your brain? Who's bringing the information to your central nervous system? That is also your peripheral nervous system. So peripheral nervous system is basically what? They are the pathway to and from the central nervous system, so that you can take the action based on the information you have received from your what? From the environment. Does it make sense? Clear? So this is something we have already talked about. Do you want me to go over one more time? So we know that whoever is taking the information toward your central nervous system, which is your afferent pathway, and we call those neuron our sensory neuron, right? And whoever is taking the information from the central nervous system to your muscles so that you can take action, those are called, they are exiting the central nervous system. So these are what? Efferent. Okay, so we know that we have different type of the muscle. We have our skeletal muscle, which is voluntary. So a lot of the time, if you are what, if you are activating your somatic nervous system, for example, whenever I'm asking you a question, you are nodding your head. Whenever you are nodding your head, what you are doing actually? You are activating your what? You are making your which muscle to actually take that action, which is your skeletal muscle. Whenever that happens, we call it what? Somatic nervous system. But what if you take the information and then you are telling your cardiac muscle to do something, your heart to do something, or your stomach to do something, or your blood vessels to do something? That is happening in your what? Autonomic nervous system, which is autonomous. So auto means what? That is not in your will. That is happening autonomously. Okay, so you have two main division of the autonomic nervous system. One is called the sympathetic. When we say sympathetic, what do we mean by that? What do we mean by the sympathetic? Sympathetic means fight or flight. So when we say fight or flight, what does it mean? A lot of the time, if you are just alert, that is also your sympathetic tone. But parasympathetic is what? When you are relaxing, trying to sleep, rest and digest, right? That is your parasympathetic division. We will talk about all those division like very descriptively in the next chapter, which is your chapter 14. Okay. However, let me ask you a question. So when we say sympathetic division and the parasympathetic division, do you think during the sympathetic division you are digesting your food a lot? No, that is happening whenever you are what? You are actually relaxing, you are in a good mood. That is when you are digesting properly, right? And when we say sympathetic tone, like for example, you guys are like really alert, trying to listen, trying to learn what is happening, you have your sympathetic tone activated. So now, for example, a tiger came into the room, what is going to happen? So you will have your sympathetic activated or parasympathetic activated? Sympathetic. Do you know something interesting? What if your crush enters the room? Sympathetic. Both tiger and the crush have the same impact on your body. Okay. So now let's talk about the parasympathetic. We will talk about all those in the next chapter, but parasympathetic is whenever you are calm, not stressed out, right? And what? Your body is working properly during that time. That is called the parasympathetic division. So now let's start with the receptor. The reason I want to start with the receptor is because for every single thing that you do in your body is happening in response to the information you are taking from the environment. So what are the information that you can take from the environment? Only the information which you have the capability to receive, right? For example, if you think about like all the electromagnetic wave right now in this room, okay, you are probably only be able to see that the visual spectrum, right, which is very small range of the what wave, right? There are so many things which is around, but you are not able to sense those, right? What about the ultrasound? Like we can only hear 20 hertz to 20,000 hertz. Why? The reason that is the only specific what? Only specific sound wave that can vibrate stimulate our hair cell, which is the receptor for hearing. Okay? Anything less or anything more than that, you cannot actually hear. So what does that mean? To be able to take action and to be able to receive the information from the environment, you should have the receptor which has the capability to take that take that information. So you have, based on the stimulus type, you have 5 different type of the receptor. One is called the mechanoreceptor. So when we say mechanoreceptor, what do we mean by that? Mechanoreceptor is what? That's a general sense, like your touch, pressure, vibration, and stretch. Let's talk about the thermoreceptor. So when we say thermoreceptor, just listen to it carefully because I have some question in your exam about that. So when we say thermoreceptor, like for example, which temperature do you all like? 70 degree Fahrenheit? I like 70 degree Fahrenheit. Some of you probably like 60 degree Fahrenheit. Some of you probably like 80 degree Fahrenheit. I don't know. People have their own choice, right? So now if you are keeping yourself always in the 70 degree Fahrenheit and then it is turning into 55 or 60 degree Fahrenheit, I'm gonna start feeling cold, right? That is something you can actually understand because of the thermoreceptor that you have. But what if that 70 degree turns into 80 degree? You're going to start feeling hot. That is also happening because you understand that what? That is happening because that is happening due to the what? Thermoreceptor. Now let me ask you a question. So you like 70 degree Fahrenheit, you stay in the 70 degree Fahrenheit. Now for all of a sudden the temperature turned into 0. What do you think is going to happen? Do you think that drastic change is what? You sense it by your thermoreceptor? No. What if the temperature from 70 degree turned into 250 degree? So what do you think is going to happen? Do you think that change you can what? Receive by the thermoreceptor? No, even though they are talking, there are changes in the temperature. However, your body does not accept or receive that signal of the temperature change by your thermoreceptor in that case. In that case, which receptor is helping you to understand that drastic change? That is called the nociceptors. So nociceptors are sensitive to pain causing stimuli. So when there is extreme heat or extreme cold, that is your body perceive that as painful. So that is why that is going to be received by nociceptors. It could be also excessive pressure. It could be also what? Inflammatory chemicals. Okay. So other two receptor, your photoreceptor and the chemoreceptor is kind of easy. So when I say photoreceptor, everyone knows that visible light spectrum of wave that can stimulate your retina so that you can see. That is what is received by the what? Photoreceptor. What about your chemoreceptors? Why can you smell something? The reason you can smell something is because the chemicals from that specific thing which is going to your nose and then stimulating the receptor so that you can take that information. Similar to that, taste. You have the taste bud for that. If the specific chemical is what? Sensitizing or stimulating your taste bud, then you can actually what? Receive that signal. So that is happening by the chemoreceptor. Smell, taste, change in the blood chemistry. Okay. So these are based on the stimulus type. Now let's talk about the classification of the receptor based on the location. Some of the receptors you have outside of your body, some of the receptor you have inside your body. So what are the receptors that you have outside the body? So whatever we have outside the body, we call them exteroceptors. So respond to stimuli arising outside body. Receptors in the skin for touch, pressure, pain, and temperature. Most special sense organs. So when we say most special sense organ, first of all, you need to know the difference between the general sense and the special sense. What do we mean by the special sense? If you have the specific organ in your body to receive the information from the environment, then you call it special sense. For example, for vision, you have eyes. For hearing, you have ear. For smelling, you have nose. For tasting, you have what? Tongue. So you understand what I'm trying to tell you, right? Yeah. So all these are actually outside of your body. That is why these are called the exteroceptors. So I'm trying to go deeper into all these different types is because I did ask a lot of questions about that. Okay, so make sure you really understand what does it mean. Okay, so the questions could be like, a scenario is given to you and then you are asked, is it happening due to this receptor or that receptor? Which receptor is stimulated, right? Okay, so now let's talk about the interoceptors. So as you can see, another name of the interoceptor is actually what? Visceroceptor. So when we say visceroceptor, viscera, what is the meaning of viscera? Organ. Okay. Very good. So for example, you have stomach upsets, like upset stomach. How are you going to understand that? Because of the visceroceptor. Respond to stimuli arising in the internal viscera and the blood vessel. Sensitive to chemical changes, tissue stretch, temperature changes. Sometimes cause discomfort, but usually person is unaware of their working. So you do not care, you don't know how your stomach is working at this point. You are not telling your stomach right now, don't worry about the digestion. You are not telling your stomach to do that. But right all of a sudden, whenever you have your stomach ache or stomach pain, you're gonna be like, oh my goodness, what's happening, right? So you're gonna probably go see doctor and trying to find out what's wrong that is happening, which is causing this problem, right? Now let's talk about the proprioceptor. This proprioceptor is very tricky. The reason the proprioceptor is tricky is because it responds to what? The stretch in your tendon, in your muscle, in your joint, in the ligament and connective tissue covering of the bones and the muscle. Inform brain of one's movement. Okay, and which is very important for you, of course. And just to let you know, this proprioceptor does not get adapted. So when I say adaptation, what does that mean? Whenever you have like if you are stretching these hands like so much that you're gonna start like you're not gonna stop feeling that stretch. It's gonna be there. But did you ever have that happen? If you go to someone else's house, right after you enter the home, you are gonna start feeling a different type of the smell. I don't know if you have ever had that. But when, yeah, so when you stay there for 5 minutes, 10 minutes, 15 minutes, you are not gonna what? Smell that anymore. Why? Because your chemoreceptors get what? Adapted. However, your some of the receptor like nociceptors, whatever is causing too much of pain in your body, you are not gonna get adapted to that. If something like proprioceptors, your tendon ligament is too much stretched, so you cannot get adapted to that. Okay, so now let's talk about something important, so which is the processing, how your receptor is working. Why do you think your receptor is getting stimulated? Every time we say stimulated, what we are trying to actually talk about, what is the main important thing that is happening when we say your receptor is getting stimulated? Huh? Why? Chemically, what is happening? You are generating the action potential. You are generating the what? Action potential. After you generate the action potential, you what? Transmit that action potential with the peripheral nerve to your central nervous system, so that your central nervous system can tell you to do something, right? So now let's talk about the processing at the receptor levels, generating a signal. For sensation to occur, the stimulus must excite a receptor and the action potential must reach the central nervous system, right? If it is not reaching the central nervous system, you are not gonna be able to understand what's going on. So what do we mean by that? It means you can probably, okay, let me tell you, you are probably seeing something which is stimulating your, not seeing something, a lot of the visible light from this projector right now is probably stimulate your retina, right? After the stimulation happened, do you think you see it with your eyes? You do not. You see it with your brain. Only after you send the signal from your receptor to your brain, then only you will be able to sense that. Okay, so that is what is very important. It's not only generating the action potential in the receptor level, but also you should definitely do what? Send it to central nervous system, so that you can actually sense what is happening. The hearing is happening inside your brain, seeing is happening inside your brain, okay, tasting is happening inside your brain. All the special sense organs that we are talking about, these are just the what? Equipment to be able to get stimulated by the information from the environment. But the processing of the information is happening inside your central nervous system. So stimulus energy must match the receptor specificity. stimulus must be applied within the receptive field and transduction must occur. Transduction must occur. Energy of stimulus is converted into first graded potential. Can anybody remind me what is the graded potential? So every time we say that the graded potential, we know that normally in your cell is in what? Negative 70 millivolt. If there is a slight change, maybe negative 60 millivolt, then what is that? This is your graded potential. This graded potential is not enough to generate the what? Action potential. Only if they reach the threshold, which is the 55 millivolt, that's when what is going to happen? They are gonna generate the action potential. Right after you generate the action potential, what do you have to do? You will have depolarization, hyperpolarization. And how do you do the transduction? After you generate the action potential, what is that? This is all or none. So what does that mean? Right after it's generated, it is going to be transmitted. And how it is going to be transmitted? Depolarization, hyperpolarization, depolarization, hyperpolarization, depolarization, hyperpolarization. Does it make sense? Yeah, everyone? Okay. Yep. So transduction or transmit the signal. So you generate the action potential. So your sensory organ is getting stimulated. But I am telling you, after sensory organ is getting stimulated, it is not going to what? Help you to understand what is happening unless it is going inside your what? Central nervous system. That is called the transmission, going from your receptor to your central nervous system, the transmission. Okay. Yeah, transmission, transduction, yeah, same thing. So transduction must occur. Energy of stimulus is converted into graded potential called the generated potential or receptor potential. So graded potential must reach the threshold to generate the action potential. So after you generate the action potential, sometimes you have, do you think, so you can have the same stimulus around you for the whole entire day? Do you think you are going to start generating, keep generating the action potential? No, you're gonna eventually get adapted. Okay, so these are called the adaptation, change in sensitivity in the presence of the constant stimulus. Receptor membrane become less responsive, receptor potential decline in frequency or stop, and phasic receptor first adapting send signals at the beginning or end of the stimulus. Example, receptor of the pressure, touch, and smell. However, there are some what? There are some receptors we call tonic receptors. They do not get adapted. Like for example, if you are in extreme pain, like for example, yesterday I had some procedure in my teeth, and from then I started having so much of pain, and it's not stopping. It's like there, right there. I keep, yeah. Like with endorphins, I thought the purpose of those was to like numb pain, right? So how does that kind of tie into this? So in that case, you are stopping the action potential. You are stopping the transmission of the action potential. That is the way, right? Like for example, whenever I had the anesthesia right here, yesterday I had anesthesia right here, and then I was not able to feel the pain because anesthesia was helping me not to transmit the what? The action potential that is generated, right? So now I feel the pain because there is nothing which is blocking that action potential transmission, right? And it's there. Even whenever I was sleeping, it was there. I can feel that right after I woke up with the toothache. It's there. It didn't go. Okay. So now let's talk about processing at the circuit level. So when we say circuit level, what do we mean by that? So we know that our neurons are not like, you only have one neuron which is doing everything. No, you have a circuit of neuron, right? You have one neuron after another neuron after another neuron after another neuron. So if you have a circuit of the neuron, what do you want to do? You generate the action potential, and then at the axon terminal you are secreting the what, neurotransmitter, so that that can generate the action potential to the next one, right? Does that make sense? So that is how you keep what, transmitting the action potential until it takes the action. So pathways of three neurons conduct sensory impulses receiving from receptor upward to appropriate cortical region. First order sensory neuron conduct impulses from receptor level to spinal reflexes or second order neuron in the central nervous system. And second order sensory neuron transmit impulses to third order sensory neuron, and from third order sensory neuron which conduct the impulses from thalamus to the somatosensory cortex. So do you understand, like, what are the levels of the information that is going from your receptor to your actual what, sensory part of your brain, right? You already know what are the different parts of the brain which is responsible for what type of sensation, right? To go to that specific part of your brain, they have to go through the first order sensory neuron, second order sensory neuron, and the third order sensory neuron. So now let's talk about the nerve structure. So when we say nerve, what do we mean by that? Do we mean that this is only one neuron? What do we mean by the nerve? Is the nerve one neuron? No, right? It's almost like your muscle. When we say muscle, muscle is not made up of one muscle fiber, right? Similar to that, your nerve is not made up of one muscle, one neuron, right? Instead, when we say nerve, we are talking about a collection of the neuron, okay? First of all, exactly like your muscle, your nerve also is made up of a group of or a bundle of neuron. We call it fascicle. What do we call it? Fascicle. Exactly like your muscle. So you have the nerve. Nerves are made up of the fascicles, and fascicles are basically what? Made up of the collection of neuron. So first level is the nerve. Nerves are made up of fascicles. Fascicles are made up of neuron. So now, similar to your muscle, in your nerve also you have three membrane or layers surrounding the each specific part. So all the fascicles together, the nerve is actually what? Surrounded by epineurium. Your fascicle is surrounded by perineurium, and your neuron is what? By endoneuron. So bundle of myelinated and non-myelinated peripheral axons enclosed by the connective tissue. So two types of nerves, spinal or cranial nerve, depending on where they originate. So when we say spinal nerve and the cranial nerve, what are the differences between the spinal nerve and the cranial nerve? Spinal nerves originate from spinal cord, and cranial nerves originate from brain. So how many cranial nerves do we have? Huh? 12? 12 pairs. And how many spinal nerves do we have? Huh? How many? 31 pairs. We have 31 pairs of the spinal nerve. We did talk about those in the lab. It looks like everyone forgot. Remember, we talked about all the 31 pairs of the what? Spinal nerve, and 12 pairs of the cranial nerve. So now, what do you think about the nerve? So we know that some nerves are sensory, take the information from the environment, and some nerves are motor, which are attached to your muscle so that your muscle can take the action, right? We call them motor nerve. Sensory nerve take the information, and but some nerves are actually mixed nerve. Just to let you know, all the 31 pairs of the spinal nerves that you have, all of them are mixed nerve. But the cranial nerves, how many cranial nerves you have? One more time, 12 pairs. What are those? You have the olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial. I'm not going over all of them, but you see what I'm trying to tell you. So in the cranial nerves, some cranial nerves are sensory, some are mixed, some are what? Some are motor. But all the 31 pairs of the what? Spinal nerves are what? Mixed. They are mixed. So now let me tell you something important, which is called the regeneration of the nerve fiber. Now I'm sure you're going to be like, what are you talking about? Are you serious? Regeneration of the nerve fiber? How does it even happen? From the very beginning, you have been telling us that your neurons are mitotic. If there is, for any reason, you have damage in the neuron, you're going to lose them forever. Did I say that? Yeah? Did I say that? Of course I did say that. And that is true. That is true. However, there is a however all the time. What is that however? Let's talk about the however. However is, if you have any kind of damage in your central nervous system, which is your brain and the spinal cord, you are losing them forever. However, if there is slight damage, not like the whole entire damage, slight damage in the axon, in the peripheral nerve only for the peripheral nerve, not for the central nervous system, that is when the regeneration is possible. But how the regeneration is happening? Not by mitosis. Just to let you know, it is not happening by the mitosis. The way I keep telling you, your neurons are mitotic, which is still true. Does it make sense? But is it making sense that when you can regenerate? Only you have slight damage in the axon of the peripheral nervous system. That is when the regeneration is possible. Mature neurons are amitotic, but if the soma of the damaged nerve is intact, so soma is supposed to be intact. If you are damaging soma, you cannot regenerate that. The peripheral axon may regenerate in peripheral nervous system, does not occur in the central nervous system. I repeat, does not occur in the central nervous system. So how? Now let's talk about the PNS or peripheral nervous system axon. So we know that the peripheral nervous system axon is what type of myelination occur, what type of cells actually myelinate the peripheral nervous system axon? Schwann cells, very good. Yeah, so PNS axon can regenerate if damage is not severe. Axon fragments and myelin sheath distal to injury degenerate. Degenerate means what? After you have breakage in the myelin sheath, what do? Damage in the myelin sheath, what do? You break it down properly. That is called Wallerian degeneration. Degeneration spreads down the axon. Okay, that is happening once you have a slight damage in your myelin sheath. You are going to degenerate the whole, you are going to break down whole entire what? Myelin sheath. So now after you break it down, you have to clean that specific part. How do you clean that specific part? The way to clean that specific part, you have specific type of cells for that. We call them macrophages. So the macrophage actually can phagocytize, clean dead axon debris. Then what happens? Just to let you know, Schwann cells are not what? Neuron. They are neuroglia. Remember, you had two different type of the cells, neuroglia and the what? Neuron. I'm still on point. I'm still telling you your neurons are mitotic. However, your Schwann cells are stimulated to divide. So don't think that I'm talking about neuron. I'm talking about what? Schwann cells, which is not neuron, which is what? Neuroglia. they can divide. Now axon filaments grow through the regeneration tube, and axon regenerate and new myelin sheath forms. Does it make sense? Is it clear? Yeah. Damaged, the damage is going to go through the whole axon myelin sheath. Hmm? Yeah, yeah, yeah. So that's something, let's talk about that. So you have this axon damage right here. So you're gonna start actually, the axon transport is interrupted. It is interrupted. So the transportation is interrupted. So you can sense that already, causing the cut ends to swell. Without the access to the cell body, the axon begins to disintegrate distal to the injury. Okay, so they start even not in the specific damage part, it is started happening what, due to, because you can sense that there is a problem right there, so you do not want to keep it anymore, you want to just start degenerating. Okay. Yeah, yeah, it's not slightly connected to each other, but they can communicate with each other, right? So if there is a problem happening in one cell, you can actually transmit that problem to others, and then all of them start getting degenerated, and then you have your macrophage come. After macrophage come, they are gonna what, clean up, phagocytize everything, and then you have the new what, Schwann cells that are going to be regenerated. Okay, so Schwann cells line up along the tube of remaining endoneurium, forming a regeneration tube that guides the regenerating axon sprouts across the gap of their original contract. The Schwann cells protect and support the regenerating axon and ultimately produce a new myelin sheath. That is only happening where? In the peripheral nervous system. I did ask questions, at least 2 or 3 about that. So make sure you understand, whenever I am talking about it, I was trying to trick you in the question. Like, is it like central nervous system, this is happening? And you are going to be like, yeah, I heard that there is regeneration. And you're going to write like, this is true. But that's not true. You have to be careful about each specific word in one specific sentence. Yeah. Only axon, no. If it is happening in the cell body, you cannot regenerate that. The axon in general. Okay, so everyone knows about the cranial nerves. We have been talking about that for many times. Is there anybody who can tell me right now in a very short time what are the 12 pairs of the cranial nerves? You did that last week, right? You can do that again, very quick. Olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, hypoglossal. So this is not the important part for this chapter right here. What is important for this chapter is actually which one is sensory and which one is motor and which one is what, mixed. How do you remember that? Remember the mnemonic? Who remember the mnemonic? Some says money matters, but my brother says big brain matters more. That is telling you which one is what type of the neuron, right? So that is the answer. However, cranial nerve, so for the peripheral nerve, you do not have to learn about any mnemonic. It is easy. Why? Because peripheral nerves, all of them are what? Mixed nerve. All 31 pairs of the spinal nerves are actually what? Spinal nerves are actually what? Mixed nerve. And we did talk about this before, just to remind you one more time. So you have 31 pairs of the spinal nerve. 8 is arising from the cervical nerve, or what, your cervical vertebra, right? We call them cervical nerve. And next 12 from your thoracic vertebra, we call it thoracic nerve. And 5 from the lumbar, we call it lumbar nerve. 5 from the sacral, and 1 from the coccyx or coccygeal nerve, right? So these are all coming from your specific part of your vertebral column, right? We know that you have all these pairs. Last sacral vertebra and your coccyx are actually what? Made up of the fused vertebra, right? And from the sacral you have 5 pairs, and from the coccyx you have 1. Okay, so now this is very important and I want you to understand that carefully. So whenever we talked about the spinal cord in the lab, we did talk about the dorsal horn, the ventral horn, and we also talked about the what? Lateral horn, right? But now what I'm going to talk about is slightly different from the horn. What I'm going to talk about, definitely these are dorsal, ventral and lateral. However, I want you to understand something important. So first of all, we know that you have your spinal cord right here, right? Spinal cord inside your vertebral column. So now you have this spinal cord right here. You have the dorsal, ventral, and the lateral. And we know that you have the dorsal root ganglia and everything. These are for the nerve, which are very close to the spinal cord. After coming out from that part, like this part right here, they will have some branches. Those branches could be many different type of the branches. Okay. When I say many different type of the branches, what does that mean? It means some of them could be sensory, some of them could be what? Some of them could be motor, some of them could be, all of them are mixed. So when I say mixed, what does that mean? They can do both. All the 31 pairs of the nerves that are coming out, they can do actually both. Okay, I was just trying to trick you. You fell for it, so don't fall for it. Okay, so all of them are both mixed. So now let's talk about the nerve which are coming out from the dorsal side. What do you think they are gonna go? Just to let you know, the branches of your spinal nerve are called the ramus. Singular, what do you call it? Ramus, and the plural you call it rami. Okay, so you can have 3 different branches: posterior branches or the dorsal rami, and the anterior anterior or the ventral ramus, and the meningeal branch, which is inside your what? Meninges. Okay, so now let's talk about the posterior or the dorsal rami. So whatever branches is going to the posterior or dorsal, they are going to innervate the what? Your back, right? Your back. It's not making sense. Dorsal means what? Posterior, back. So whatever branch is coming out, which is the dorsal rami, they are going to innervate the what? Your back, right? And then what about the other part? We will talk about that. And the anterior part is the what? The back. So the dorsal rami is like really small, because they do not have to go to so many, from the vertebral column they do not have to go to so many different places. They can just what? Innervate your back. So these are very small branch. But if you think about the anterior branch or the ventral rami, what is happening with the ventral rami? What is happening with the ventral rami? They are going to so many different places of the body. So what does that mean? It means that they are gonna be like really long. And what about the meningeal branch? The branch which is going inside the meninges, that is called the meningeal branch. Tiny branch that re-enters the vertebral canal to innervate meninges and the blood vessel. Now let's talk about the rami communicantis. Communicantis is coming from the communicate. Whenever 2 nerves are communicating with each other, that is called the what? Rami communicantis. Contain the autonomic nerve fiber that join ventral rami in the thoracic region. So now, as I told you, this dorsal is going to only innervate the what? Back. But the anterior rami is going all over your body, right? And these right here, you can see that how two nerve communicating each other with each other. This is called the what? Rami communicantors. So now let's talk about something important. Nerve plexuses. Except T2 to through T12, all the rest of the what? Nerve actually do what? Make connection with each other. Remember we talked about it? We talked about the root in the lab. What did we talk about? Who can tell me? If Rebecca is sending me an email saying, I cannot come to the class, professor, because the route I take to come to the class is closed. What are you gonna do? What I'm gonna reply? Huh? I'm gonna reply, take another route. Right? Take another route. So what does it mean? What is the function of our spinal nerve? To innervate the different parts of the body. Just to let you know one more time, all of them are mixed. That means they not only send the information, but also what? They bring the information, right? So now, for example, if we were talking about the spinal nerve, which is going to innervate your what? Innervate your shoulder, like deltoid muscle right here, which is your axillary nerve. So do you think axillary nerve has one way to come to the spinal cord? No, it does not. It can come to the spinal cord in different route. Okay, so why that is possible? The reason that is possible is because this axillary nerve is not coming in only one route. There is another nerve which they are trying to make what? Connection with, right? So now these axillary nerve to the spinal cord, they can come with this route, they can come with this route, they can come with this route, they can also come with this route. Does it make sense? And these are called the nerve plexuses. What do you call it? Nerve plexuses, found in cervical. So how many different type of the nerve plexuses do we have? We have 4 different nerve plexuses. The one in the cervical region, cervical plexus, the one in the brachial region, brachial plexus, the one in the lumbar region, lumbar plexus, in the sacral region, sacral plexus. So found in cervical, brachial, lumbar and the sacral areas, only ventral rami form the plexuses. Each branch contains the fibers from several different spinal nerves, and each limb muscle is innervated by more than one spinal nerve. So damage to one does not cause paralysis. So what does that mean? If one route is what? Closed, Rebecca can come to the class in another route, taking another route. Similar to that, you can still take the information from here or send the information to your deltoid muscle, even though if one nerve is damaged for some reason. Does it make sense? Yeah? Okay. So now let's talk about the cervical plexus. First, 4 ventral rami, which is from C1 through C4, from looping cervical plexus. Most branches of these form the cutaneous nerve that innervates skin of the neck, ear, back of the head, and shoulder. Innervate the neck muscle. So in your exam, I'm going to ask for all different cervical, all different plexuses, what are the major nerve of the specific plexus. Just to let you know, we have 31 pairs like the cranial nerves. I do not want you to learn about all 31 pairs. However, I at least want you to know about what? The major nerve from the specific plexus. From the cervical plexus, the major nerve is what? Your phrenic nerve. Have you ever heard of that? Which is going to be innervated your what? Very important part of your body, which is called the diaphragm. So for any reason, if the phrenic nerve is damaged, what do you think is going to happen? They only have the 2 route to go there. And if you are actually damaging both of the nerve, what do you think is you cannot do? You cannot breathe. Very good. Because the diaphragm is a very, very important part of your what? Breathing, inhalation and the exhalation. If you do not have the what? If you do not have if the nerve is damaged, the phrenic nerve is damaged, they have two routes. If both of the routes are damaged, then you cannot breathe. If you cannot breathe, what is going to happen? Are you going to be alive? No, you have to actually come up with another way to breathe. So mechanical breathing. So you have to come up with another type of breathing. Major motor and sensory nerve of the diaphragm, major muscles for breathing. Phrenic nerve receives the fibers from the C3 to C5. So irritation of the phrenic nerve causes spasms of the diaphragm, also called hiccups. If both phrenic nerves are severed, then C3 to C5 regions of the spinal cord is destroyed, diaphragm becomes paralyzed. Respiratory arrest occur, victim requires mechanical respirator to stay alive. Air is mechanically forced into the lungs, literally breathing for them. Okay. Now, the biggest one, your brachial plexus. It has five major nerves. So first of all, you have the axillary nerve, which is going to innervate your deltoid muscle, right? Shoulder muscle. Not only deltoid, but also teres major sensory input from the superolateral arm. What about the median nerve? Your median nerve is going to innervate most of your what? Forearm muscle, and hand muscle, sensory input from the palmar side and dorsal tips of the most finger. And we did talk about in the lab very, very thoroughly, which is your musculocutaneous nerve. What is going to be innervated by the musculocutaneous nerve? Your biceps brachii and sensory input from the lateral forearm. What about the radial nerve? Is coming this way. Radial nerve is going to what? Posterior arm muscle, like triceps brachii. Posterior forearm muscle, sensory input from the posterior arm and the forearm and the dorsolateral hand. What about the ulnar nerve? That is a very, very what? Prone to injury. Okay. Ulnar nerve to the anterior forearm muscle, most intrinsic hand muscle, sensory input from the palmar and dorsal aspect of the two medial fingers. So this is like the real picture, real human picture, where you can see all the plexus right here, and from all the plexus how the nerves are making the junction so that they can have different route to go to the different ways. Okay, and then these are the specific nerves right here. So as I told you, your ulnar nerve is very, very prone to the injury. Severe or chronic damage to ulnar nerve can lead to sensory loss, paralysis, and muscle atrophy. Everyone knows what is atrophy, right? If you are losing the sensation of the specific muscle, what does that mean? It means that you cannot actually use that anymore. If you cannot use that anymore, what is going to happen? Disuse atrophy. You are going to lose it. Don't use it. If you do not use it, you are going to lose it. That is the what? Atrophy. The affected individuals have trouble making a fist and gripping objects, and gripping is a very important function, even though I don't think you guys are aware of that, but it is a very important function and also a very good predictor of the longevity too. So as we grow older, our gripping capability actually what? Decreases. Affected individuals have trouble making a fist and gripping objects. Little and ring fingers become hyperextended at the knuckles and flexed at the distal interphalangeal joints. Causes hand to contort into a claw hand like this, striking the funny bone. What is the funny bone? Who remembers? Medial epicondyle, right? The spot where this nerve rests against the medial epicondyle can make the little finger tingle. Now let's talk about your lumbar plexus, which is going to innervate your lower extremities, innervate the thigh, abdominal wall, and psoas muscle. So major nerve here is the what? Femoral nerve. Just to let you know, in your exam, IDs ask question about what is the major nerve for the lumbar plexus? What is the major nerve from the brachial plexus? What is the major nerve from the sacral plexus? Right? So make sure you know that and you know their function. Yeah, you have question? Yeah, whatever I'm going over, these are the one for the test. You are not gonna see anything else which I'm not talking about. So the femoral nerve, major nerve in the lumbar plexus. So femoral nerve is going to what? Innervate which part right here? Your quadriceps, right? Major nerve in the lumbar plexus innervates the quadriceps and the skin of the anterior thigh and medial surface of the leg. There is another nerve right here. This is called the obturator nerve. We did talk about it in the lab. Which muscle you have in here? Adductor muscle, right? The adductor muscle is what? Innervated by your obturator nerve. So this is a like really nice and beautiful chart which is talking about what are the different nerves that are coming out from the brachial plexus, what are the ventral rami, the number of the number right here, and then what are the structure they are served. For the femoral, we already know that's your quad, right? For obturator, we already know that is your adductor, magnus, longus, brevis muscle, gracilis muscles, everything in the medial side, right? These are by the obturator muscle. And lateral femoral cutaneous, skin of the lateral thigh, some sensory branches to the peritoneum. What about the ilio, hypogastric, skin on the side of the buttock and above the pubis, muscles of the anterolateral abdominal wall. Ilioinguinal, skin of the external genitalia and proximal medial aspect of the thigh, inferior abdominal muscle. Just to let you know here, one thing which is, if you look at the name is already telling you a lot, right? What about the genitofemoral? Skin of the scrotum of the males, of labia majora in female, and of the anterior thigh inferior to the middle portion of the inguinal region, and what? Cremaster muscle in the male. Sciatic nerve. You guys are familiar with the sciatica? Very painful, right? Sciatica. Is there anybody who is experiencing in your family? Are you by yourself? Oh my goodness, I'm so sorry. It's a lot of pain, yeah. Serves the buttock, lower limb, and pelvic structure and the peritoneum. So sacral is basically the what? On the back, posterior, right? So sciatic nerve, it has actually two part. Longest and thickest nerve of the body. Innervate hamstring muscle on the back, as I told you, adductor magnus, and most muscle in the leg and the foot. Composed of two nerves, as I told you, tibial and the common fibular. So sciatic nerve has the tibial branch and the fibular branch. So they have different structure they are going to serve. Now let's talk about some of the non-major, like your superior gluteal, inferior gluteal. What is the name telling you? Gluteal is what? Your glute muscle, right? So your superior gluteal is going to medius, gluteus medius and gluteus minimus, and your inferior glute muscle is going to what? Innervate the gluteus maximus. And then posterior and the femoral cutaneous, the name is already telling you what they're going to do. Skin of the inferior buttock, posterior thigh, and the popliteal region. Length varies, may also innervate part of the skin of the calf and the heel. Then the prudental supplies most of the skin and most of the what? Perineum. Okay, so as you can see, sacral plexus, sciatica, very, very painful. A common problem is characterized by stabbing pain radiating over course of the sciatic nerve. Injury could be caused by a fall, disc herniation, or badly placed injection into the buttock. Why did you have that though, Tori? Why did you have that?
Not certain.
You're not certain. Oh
Yeah, I
wow.
literally woke up one day with pain shooting down my leg.
Seriously?
Yeah.
Wow. It's very hard, as I told you.
Far, I've done nerve ablation and physical therapy.
So this is happening in the spinal nerve though. Just, yeah, spinal nerve. So these are peripheral nerve. So if there is anything peripheral, there is a possibility to make it better, the way she was saying all the procedures, but still hard, very hard. Anything associated with the nerve damage, very hard to actually like go, like really going back to the original state. It's very hard. Yeah, as I told you, as she is telling, the physiotherapy helps. Physiotherapy helps, but physiotherapy helps most of the time for two ways. One way is like you are still trying to use those muscle, and another way is actually whenever you was trying to use those muscle in another way, you are trying to actually whatever nerve or whatever brain part you have already intact, you are trying to switch the function that is happening by another part of your uh, brain. Like, do you remember that example that I gave you? Like, for example, we know that we have the Broca's area in one part, and another part on the same side, we have the another part on the other side. What do we have? We have something which is responsible for understanding the non-verbal cues, right? So now, for example, if you cannot talk, or maybe if you cannot understand someone's voice, this is for talking. Broca's area is responsible for talking. You cannot talk, the other part becomes, for your survival, becomes more active. Like that, that is what I was trying to tell you. So for some reason one part is not working, if the same function could be done by another part of the brain or spinal cord, there is a possibility that you are making it more active and functional. But actual regeneration and actual change, like it's very hard. It's, yeah, it's very hard. So if the nerve is transected, leg is nearly useless and cannot be flexed because hamstrings are paralyzed. Foot and ankle cannot move at all, so foot drops into a plantar flexion, pointy toes, a condition called foot drop. Recovery from sciatic nerve injury is usually slow and incomplete. For lesions below knee, thigh muscles are spared. If tibial nerve is injured, paralyzed calf muscles cannot plantar flex foot, and a shuffling gait develops. Okay, so we are gonna end with this chart today. Very important chart. At least few questions are asked from here. So you have your cervical plexus, major nerve is your phrenic nerve, brachial plexus, axillary musculocutaneous, median radial ulnar. The question could not only be what is the major nerve for the specific plexus, it could be what is the major part of the body which is innervated by this specific plexus. So lumbar, femoral, obturator, and your sacral, sciatic, even though sciatic has both tibial and the fibular. Okay, so let's stop it right there. We are gonna start from the intercostal nerve next class. Okay, and then I'm gonna take your attendance, and with that, let's complete chapter 13. Okay, so we did talk about this one already. So one nerve we did not talk about, which is your intercostal nerve. So when we say intercostal nerve, what do we actually mean by the intercostal nerve? First of all, in between the ribs. Very good. If it is in between the ribs, what does it do? It supplies the muscles of the ribs, anterolateral thorax, and abdominal wall. Okay, it's very intuitive, so not very hard to understand. Okay, and also it gives off cutaneous branches to skin along the course. So one more important thing is, like, we have been only talking about the innervation to our muscles, right? What do you think about the skin? What is going to the skin? So each of the nerves that we have talked about so far, all the 31 pairs of the nerve that you have, not only they are going to innervate your muscle, but also they are going to innervate the specific part of the what? Skin. And that is, and there is a map for that to the physician, so that if anybody has problem sensing at specific part of your skin, they can try to find out if there is that specific nerve that is damaged or not. Okay, and that is called dermatome. Okay, so the dermatome is the area of the skin innervated by the cutaneous branches of the single spinal nerve. Except C1, all the rest of the 30 pairs of the nerves are actually what? Responsible for innervating your skin. Extent of the spinal cord injuries ascertained by the affected dermatomes. Most dermatomes overlap, so destruction of a single spinal nerve will not cause the complete numbness. So, which is very good news for you. Okay, so it's almost like your nerve plexuses. Due to the presence of the nerve plexuses, if any of the plexus is what? Any of the nerve is damaged from that plexus, you will still be what? Getting the information from that specific part of the body, right? Okay, so let's see how much you all remember. Who remember about the nerve fascicle? So when we say nerve fascicle, what do we mean by the nerve fascicle? Yeah, anybody? Nerve fascicle, collection of collection of what is the name of the nerve cell? Neuron. Yeah, collection of the neuron. So your a bundle of neurons are called the what? Nerve fascicle. So we know that you have the neurons. Neurons together is making the fascicle. Fascicles together is making the what? Nerve. Right? So now we also know that they have the different layers of the membrane, right? Your nerve has a membrane and your fascicle has a membrane and then your neuron has a membrane. What is the name of the membrane in the fascicle? It's not endo, that's sure. It's peri or epi? Epi? Okay. So what functions are served by the posterior rami of the spinal nerves? Who remember about the posterior rami, anterior rami? We did talk about it. Posterior rami, the short branch, right? And innervates the back. Yeah, very good. So which terminal branch of the brachial plexus innervates the biceps brachii? We just talked about it. Musculocutaneous. What is a dermatome and how can it be useful in clinical evaluation? We just talked about it. It's a map of the what? Nerve which is innervating the what? Specific part of your skin. Why it is important? It is important because what? If any of the part of the skin is not doing the what? If it is not sensing, what can you tell from there? The nerve is damaged. Yeah, that is why the dermatomes are very important to the physician. This is one of the like early evaluation, I would say, and then you can deep digger into it to understand what's actually going on. Okay, so now as we have been talking about the innervation to the muscle, we just also talked about our skin is also innervated. Now the question becomes, which part of the skin is innervated by the which specific nerve? How do you know that? To be able to know that, what you have to know is called Hilton's law, which actually tells you that any nerve serving a muscle that produces movement at a joint also innervates that joint and skin over that joint. So what does it mean? It means, like for example, if you think about your axillary nerve, if the axillary nerve is innervating your deltoid muscle, so skin on top of that is innervated by the what? Your axillary nerve. The joints, what is the name of the joints right here? Ball and socket joint, glenohumeral joint. So your this joint is also innervated by which nerve? Axillary nerve. So Now let's talk about the peripheral motor ending. This is something we have been talking about for a long time, right? We know that the language of your brain, the language of your nervous system is what? Releasing the neurotransmitter. So they release the neurotransmitter to either stimulate your neuron or inhibit, right? So now these elements innervate skeletal muscle, visceral muscle, and glands. But what happens to the skeletal muscle is something we have talked about. Maybe how many times? I forgot how many times. More than 50 times, many times, right? So this is something you are very familiar with. So what's happening? You have that axon terminal has this synaptic vesicle. The synaptic vesicle contain the what? Neurotransmitter. Anytime your synaptic vesicle is receiving the action potential, what is going to happen? This vesicle is going to get ruptured and you are going to secrete the acetylcholine. Acetylcholine directly bind with the what? That ion channel, right? Directly bind with the ion channel in the what? Neuromuscular junction, right here, right there, right? When they bind with it, what happens? The gate opens and sodium ion starts entering into the cell. This is something you should by now have memorized, right? Okay. So this is exactly what is happening in your skeletal muscle. But what do you think is happening in your like other muscle, like your heart, your glands, your lungs, your digestive system? So all of your autonomic motor endings. Just to let you know, this is more simple than your skeletal muscle. Okay. So why I say it's very simple? Because first of all, the visceral effectors are simpler than the somatic junction, and the branches form like synapses with the effector cells by the varicosities. So what does that mean? It means that we know that we have all the different type of the for the skeletal muscle. You have that specific motor neuron which is attached to your effector cell and then directly releasing the neurotransmitter and opening the gate and everything is happening. But here all the nerves, like a very varicose vein, you guys are familiar with the varicose vein, right? From there the name came, the varicosities. All these nerves are literally innervating the what? The whole entire muscle, like your glands or your lungs or your hearts, all this what? Autonomic motor system. Okay. So one thing you need to understand about the autonomic motor system is we know that for the skeletal muscle only neurotransmitter available is the what? Acetylcholine. But for your autonomic nervous system you have actually two different type of the neurotransmitter available. One is called the acetylcholine and another one is the what? Norepinephrine. And we know that definitely they are slower because they are not as myelinated as what? Your skeletal muscle. And also this acetylcholine and norepinephrine, these could be both stimulatory or it could be what? Inhibitory. But in the skeletal muscle, the acetylcholine is always what? Excitatory or stimulatory. Okay. So these are the differences. So now let's talk about the reflexes. So when we say reflexes, what do we actually mean by that? So we know that the function of our nervous system is to communicate with the environment and take a proper action. So whatever action that we take in response to the environmental stimuli, that is called the what? Reflex, right? So that reflex could be inborn. So when we say inborn, what do we mean by that? The reflex what which you are born with, and the reflex you have learned, that is your what? Acquired reflex, right? So the one you were born with, very less, actually very few, like maintaining your posture, muscle tone, right? Maybe like crying too. If you need anything you cry, so that is also reflex, right? But that doesn't happen anymore when you are becoming like 1 year, 2 years old, because instead of crying, you start saying that, right? So what does that mean? All the inborn reflexes that you have, you can actually change over time. Okay, you can learn what you have to do instead of what you are actually born with. Does it make sense? But most of the reflexes are actually what? Learned reflexes, right? So for example, sitting in this room listening to your professor is learned, right? If you now bring a 1 month old, they're not going to listen to me, they're going to start crying, right? So you see what I'm trying to say. So most of it are like driving skill, playing a piano, all these things are actually learned or acquired reflexes. So now these reflexes sometimes could be associated with the somatic, which is your voluntary. Like for example, I'm moving my hands to show you the skeletal or voluntary or somatic reflexes. So that is your somatic reflexes. But autonomic reflexes that you cannot willingly control. Like for example, if your heartbeat increases or decreases, or all these things that is happening inside your body which you do not have like direct control, that is called the what? Autonomic reflexes. So activate visceral effectors, smooth or cardiac muscles or glands. This is something, this is the picture that you have seen many times. So these are basically talking about the what? The 5 components of the reflexes. So let me not talk about it. Can you guys tell me what are the effect, what are the what components first? So definitely you have to have the receptor. If you do not have the receptor for it, you cannot take that information from the environment. Do you remember that example I gave you whenever I was talking about the hair cells in your ear? What? Your hair cells can only be stimulated by 20 hertz to 20,000 hertz. But if you have something more than that, like 30,000 hertz, would you be able to take that information? No, because your hair cells can only be stimulated by that specific range of the sound wave. Does it make sense? Everything is like that. It's for vision. You can only see the very small range of the visual spectrum, right? Nothing else. There are so many other waves that you have around, but you cannot take those information because your receptor can only be stimulated by that specific range of the what wave. So definitely you have to have the receptor. And then after you have the receptor, for the reflex, what do you have to do? You have to send this information to your central nervous system. So how do you send this information to the central nervous system? By your sensory or afferent neuron, right? And then who's gonna take the action? Who's going to take the action? It could be some kind of muscle, right? Effector, we call them what? Effector. The who's going to take the action? It could be either your skeletal muscle or your glands or your what? Autonomic motor system, like your lungs, heart, digestive system, kidney, all this, right? So we know that the effector is going to take the action. So who's going to send the information to the effector? Your motor neuron that is attached to your what? Muscle. And then do you think is this that simple? You only have one sensory neuron, one motor neuron? No, there is a what? Long circuit. So you have interneuron between them so that you can actually what? Send the information to the proper place what? Properly. We're following the what? Circuit. So these are the basic components of the reflex arc. So we can have so many different type of the reflexes. So how can you actually classify the reflexes based on spinal or cranial nerve? We know that we have our what? Central nervous system. Your central nervous system is made up of the what? Your brain and the spinal cord. So the integration center could be your spinal cord or could be your what? Your brain. So in that case, you can have either spinal or cranial. And who's going to take the action? Is it going to be your voluntary muscle, somatic skeletal muscle, or is it the gland or heart or lung or all this? So based on that, it could be somatic or visceral. And then the monosynaptic or polysynaptic. When we say monosynaptic and polysynaptic, what do we actually mean by that? Do you have one sensory neuron and one motor neuron, or do you have more? Okay, if you have more, then you call it what? Polysynaptic. And if you have one, you call it monosynaptic. Does anybody remember one of the example of the monosynaptic that we talked about during the lab? Nobody remembers? Yeah, yeah, knee jerk. Yeah, knee jerk. It's a very short reflex. It's a very short arc. That is why the what? The reflex is very, very quick. Yeah, like directly. It's like direct. So we're gonna see. We're gonna look at that. And there is another term which is called the ipsilateral and contralateral. For example, this face is itching right now in this side. So now I am going to use my hands to itch this. So this is one side of the muscle that is working to actually resolve the problem in the same side. So that is what is called the what? Ipsilateral. Like what if I want to what? I have a fly on this hand and I want to kill it with this hand. So that is going to be what? Contralateral. What about your innate or acquired? We have just talked about it. When we say innate, what do we mean by that? We are born with it. And when we say acquired, what do we mean by that? We have learned that. Very good. So now, first of all, let's start talking about the stretch and tendon reflex. So when we say stretch and tendon reflex, what do we actually mean by that? We have been only talking about the muscle contraction, contraction, and contraction. What about, have you ever thought about what if your muscle is stretched too much and you cannot feel that? Is there a possibility to actually tear your muscle tendon? Yeah, so your body has to be like really vigilant about this type of problem. So that is why you have this stretch and tendon reflexes, to be able to understand if there is somewhere in your body which is like stretched too much, right? So what is the information that you are taking by that? Do you remember we also talked about different type of the receptor? One of them was the proprioceptor. So the proprioceptor is the one which is basically responsible for taking that information. So what is the information that you are trying to understand by this proprioceptor? So length of the muscle. Is the length of the muscle getting shortened, or like what, lengthened too much? And then the information will send from the muscle spindle. So, and also they're going to take the amount of tension in the muscle, information sent from the tendon organs. So now, before we talk about the stretch and tendon reflex, I want you to understand part of your skeletal muscle have this muscle spindle. In the muscle spindle, we know that the spindle shaped muscle, you have the intrafusal muscle fiber, extrafusal muscle fiber. So in the spindle, you have the extrafusal, you also have the intrafusal muscle fiber inside the spindle. So now the intrafusal muscle fibers are actually non-contractile. However, their end region contain actin and myosin myofilament and can contract only the end region. But the regular effector fibers right here, these are actually what? These are referred to as extrafusal muscle fiber. So what are the nerves that are associated with it? So you can have the gamma efferent nerve, or you can also have the alpha efferent. So your gamma efferent go to the muscle spindle, and alpha efferent go to the muscle fiber. So you have your muscle fiber, and then the whole thing is the what? Muscle spindle. So now if you think about like what is the information that you are trying to send, whenever you have the normally unstretched muscle, you are continuously sending the information to your central nervous system that you are fine, right? But there is always a what action potential that is sent to your central nervous system saying that it is not stretched or anything, it is fine. However, if it is stretched, if it is lengthened, then what happens? The action potential actually increases. That is when you are sending the information that your muscle is stretched. But what if your extrafusal is what? Contracted, but your intrafusal is not contracted. What is going to happen? What do you think? What kind of information do you think are you going to send to your central nervous system? You cannot actually send any information in that case. So if only alpha motor neurons were activated, only the extrafusal muscle fiber shortened, the muscle spindle becomes slack and no action potentials are fired. It is unable to signal further length changes. However, if normally alpha to gamma coactivation occurs, both extrafusal and intrafusal muscle fiber shorten, tension is maintained in the muscle spindle and it can still signal changes in the length. So what does that mean? You have to actually, to send the information, you have to have your both muscle, extrafusal and intrafusal, should be what, stretched or contracted to be able to send the information to your central nervous system. So in the stretch reflexes, what is happening? We already know you have your muscle right here, muscle spindle right here. So from the muscle spindle, if you have your both extrafusal and intrafusal changed the what length, you are going to send the information to your central nervous system by the sensory nerve, and then this is going to what, send the information what, to do the what. So what is happening? So you have the two, actually you are sending two information right here. So when I say two information together, what does that mean? It means that efferent impulse of the alpha motor neuron cause the stretch muscle to contract, which resists or reverses the stretch. So in one, so this is the positive. And then efferent impulses of the alpha motor neuron to antagonist muscles are reduced. So reciprocal inhibition. So one is what is happening. So you have one muscle is getting, every time you always have to think about, like for example, if you think about your biceps brachii right here, you have your triceps brachii right here. So what you are trying to do, every time you are telling your biceps brachii to what, contract, what you are sending the information to your triceps brachii to extend, right? So this is exactly what is happening for any type of the what, muscle reflex. So everyone knows about the knee jerk reflex. That is a very common what, reflex that is tested by the you know what I'm trying to tell you. So what is happening? What do? You tap it to where, in the patella. So when you tap it to the patella, what is going to happen? You want to, you want to, which one you want to contract? You want to contract the quad so that you can do this, and you want to, what about the hamstring? You want to relax. So that is exactly what is happening. So the motor neurons send the activating impulse to the quadriceps, causing to contract and extending the knee. That is why you have this. Yeah.
So you're saying the alpha and the gamma don't go to the same muscle. The gamma will go to the antagonist of the alpha.
Yeah.
Okay.
So now the interneurons make inhibitory synapse with the ventral horn neuron that prevent the antagonist muscle, hamstring, from resisting the contraction of the quadriceps. Does it make sense? So you always have like agonist and antagonist, right? And you are always sending the two signal, one to contract, another to resist the contraction of that specific muscle by the antagonist. Okay. So now let's talk about the tendon reflexes. So we have been talking about the muscle stretch. Now everyone knows about the tendon too, right? When we say tendon, what do we mean by that? So what if there is any stretch in the tendon, what is going to happen? You want to make sure that you do not want to tear right? So to prevent the damage to the excessive stretch or contraction, important for smooth onset and termination of the muscle contraction. So first of all, if you have it stretched, you send this information, and then what is going to happen? You have your positive arm, negative arm. So as you can see what's going on right here. So efferent impulses to the muscle with the stretch tendon are damped, so muscle relaxes, reducing the tension. And what is going to the opposite one? Efferent impulses to the antagonist muscle cause it to contract. Okay, so this is something everyone kind of what familiar, right? So what happens? So we know that like if you go for the blood testing, they're gonna prick your finger to take the blood, and you know that that's a little bit painful, right? So do you wanna like give your hands willingly and to withdraw the blood? You want to, but at the same time the reflex is what? Doing this. So in our country, uh, actually I don't know, I should talk about it. So we were actually beaten for not following the rules or something like that. So they used to have the cane like that, so they would do this, huh? So every time they would do this, so what we are gonna do this, do this, you're gonna like that. So this is a very good example of your what? The flexor withdrawal reflex. So what is happening in the flexor withdrawal reflex? So you are basically the same hand which is going to be what? Yeah, that is the one you are trying to take away, right? So that is happening in the same hand, same side. So that is what? Ipsilateral and definitely polysynaptic. And so brain override, knowing a finger stick for blood test is coming, brain override pulling arm away. Yeah.
Is that the same for like cardiac muscle too? Because like you can like I can slow down like the heart rate or speed it up.
It's something, it requires a lot of expertise. It's not happening actually. You can do another indirect things to control that, but not necessarily you cannot tell, okay, right now I want to just what? Slow my heart rate. You cannot do that. What you can do, you can probably try to control your breathing to change your heart rate. Does it make sense? It's not like something you can directly do that. Yeah, but it still requires a lot of, it's not like I want to take it like this, I'm thinking it and then it's happening. It's not like that. You have to actually, what should I say, not everybody can do it too. You have to learn that process, and then it's a little bit tricky. These are all autonomous. At the same time, there is some indirect way to actually control it too. So for example, breathing, everyone breathing is what? Autonomous, right? We are, but we can still control it too. There is some voluntary part of it too, right? So similar to that, the heart rate, it is autonomous, autonomously controlled. Of course you want it to be autonomous, because without that you cannot even survive. So just imagine thinking about your controlling your heart rate all the time. So would you be able to do anything else? No, right? So definitely it is autonomous, but there are some component of it which probably you are probably be able to control a little bit slightly. Yeah. Okay, so have you ever noticed these crossed extensor reflexes? For example, if you have a what? Tear or pain in one leg. So what do you want to do? You do not want to put your foot properly right here. Now to balance, what do you have to do? You have to use another to actually, that is called the what? Crossed extensor reflexes. So occurs with the flexor reflexes in weight bearing limbs to maintain the balance. So consist of ipsilateral. This is ipsilateral withdrawal reflex. So one leg you have the damage, so that is the ipsilateral withdrawal. You are not using that properly. But contralateral crossed extensor reflex, but the contralateral you are using to what? Actually contract and walk. So example, stepping barefoot on the broken glass causes damaged leg to withdraw and opposite leg to extend to support the weight shift. Okay, everyone knows about the plantar reflex. Plantar reflex. When we say plantar reflex, what do we mean by that? The tickling, very tickling, right? So usually for the kid, when you do that, a lot of the time it is a test to test the integrity of the cord from the L4 to S2. So what do? You stroke the lateral aspect of the sole of the foot. What happens? The kids, the very, very small baby infants, they do not actually have the proper myelination. So what they are supposed to do is like they're gonna flex it downward and they will have their what you see what I'm trying to tell. The all these digits, the hallux are gonna be like fan like, right? Like pointed. Okay. So smaller toes fan laterally, normal in infancy to age 1 year because myelination is still incomplete. However, if you have damage in this, in this nerve, what is going to happen? You will not have that specific reflex. So in that case, your doctor will understand that you probably have the what? Damage to the motor cortex or corticospinal tracts causes the abnormal responses known as the Babinski sign. Okay. So what about the abdominal one? Do you know on your abdominal reflexes? Test integrity of the cord from the T8 to T12. So what is the stimulus? Stroking the skin of the lateral abdomen above, below, or to side of the umbilicus, basically right here. You just stroke it to see the response. The response is the contraction of the abdominal muscle and movement of the umbilicus toward the stimulus. So vary in intensity from one person to another, absent when corticospinal tract lesions are present. So what did you learn so far? Is the flexion withdrawal reflex ipsilateral or contralateral? Of course, ipsilateral. What is the main monosynaptic reflex? We just talked about it. Monosynaptic reflex. Which one? Knee jerk. What is the function of the Golgi tendon organ reflex? To prevent tearing of your tendon, your muscle, and all this, right? So that's all about this chapter. Does anybody have any question? If you do not have any question, we are going to start our